The topic we're talking about today is moving beyond the rhetoric. Mental health care reform has seen many positive shifts in prevention, diagnosis and treatment for a range of conditions. However, in spite of the progress that's been made, as we've already heard today, the need for evidence-based and accessible support programs is paramount to support the 1 million Aussie adults living with depression and 2 million Aussie adults living with anxiety. So I'm going to turn now to the panel to explore further the topic of moving beyond the rhetoric. I want to start with Malcolm. Malcolm, we know that thousands of Australians currently access mental health care services on a population basis. And you've already talked in your presentation a bit about evidence-based treatment, but how do we gauge treatment efficacy and how can we assess if people's mental health is really improving as a result of the treatment that they are receiving?
I mentioned cognitive behaviour therapy is one of the more well-established, recognised treatment models based on multiple randomised trials over 30 years or more. So the challenge is, how do you take an evidence-based program, 2 or 3 year randomised trial, and translate it into real-world practice? So it's not that we don't have the evidence, it's just that we have trouble translating it. So in this particular model, the underpinning infrastructure is this web-based outcome measurement system where the coach will take an anxiety measurement and a depression measurement and a couple of others every single time they talk to the client. So in theory, after the second visit, you've got an outcome measure, a pre-post outcome measure, which then can maybe be repeated by the 5th or 6th visit. So then you can look at cut-off scores and say X number of people have recovered according to cut-off scores, and there's several other ways of measuring outcomes. So that was probably one of the biggest breakthroughs in terms of a mainstream, real-world mental health service, that we could actually do that. A lot of other practitioners in Australia would be measuring outcomes at different times, but not necessarily regularly and not necessarily facilitated by a web-based automated system. So that's what's been able to give us the overall outcome measurement, and then we have follow-ups, 1 month and 6 months later, that we can review outcomes.
So that really is a new innovation, isn't it, in mental health in Australia?
Yeah.
Yeah, okay. And Amanda, you mentioned that it's taken 5 years, you said in your presentation, from its inception to now. What has taken so long to get a program like MindStep to the market?
Yeah, it's a good question, because we knew it was, as I said, the very first area that we looked at with members. It was really clear there was a problem, but we really stick to our guns on we want it to be evidence-based, and I'm a health insurer as well, our company, so we're a mutual. We have to fund by reducing admissions into hospital. And we've stuck to that philosophy in all of the programs, and we needed to find one that fitted. And we also needed to find one that fitted a model of telephonic, because we weren't prepared to put people on the ground everywhere to address this issue. So it took time to find something that really was measuring outcomes, that we could say, yes, we can see that is working, therefore we're willing to invest and fund in it, and know that the recovery rates would be there as well. So obviously it's not just about reducing admissions into hospital, it's about people getting better as well. So, and then translating it to the Australian context is difficult. We needed to know that it worked here, so we wanted to see a trial of that working in this context, and then you've got to implement it. It's a collaboration between Flinders, York University on the other side of the world, and Remedy. You've got to take time to build the relationships with people, to develop trust and to implement it. So all of that takes time, but I think things that are worthwhile are worth taking the time.
And you also mentioned, Amanda, in your presentation, the challenges with manning a program like this.
Yeah. So as I was saying, Ernst & Young have forecast 8,800 additional mental health workers. Well, that's one part of the health system. The whole health system is facing the same issue, and aged care and the ageing of the population. So the other really key thing that attracted us to this was the innovation around the workforce. As Malcolm was saying, it doesn't have to be a clinical background that comes to this. And in fact, I think you told me early on in the piece, Malcolm, that you found the best coaches that got the best outcomes were actually from a retail background. I don't know whether that's because of the customer focus or the empathy with dealing with the public. I'm not sure what made the combination, but that's very encouraging. It means there's a whole different workforce that can be tapped into here to deliver the services. So I think we've got to innovate on workforce to solve these problems, and we've got to, I guess, open our minds and some of our biases around who has to do what in the health system and look at other options.
In fact, actually, Malcolm, you said something to me when we spoke on the phone earlier, that you found that, and I'm going to shoot myself in the foot as a psychologist, but that people with in-depth, I guess, expertise, psychological expertise, were not so well suited to deliver this kind of program because they'd, perhaps you could explain why you found that to be the case.
Right. So what the coaches are trained in is a kind of a narrow component of the anxiety, depression, mental health problems in Australia. I mean, it's still a large group, but not, for example, post-traumatic stress disorder, not obsessive compulsive disorder. Two of the more complicated conditions. And what we've found when we've had fully qualified mental health professionals involved in this kind of program is they tend to drift. So partly because of their good experience, they tend not to stick to the clear evidence-based set of skills. So in fact, by taking a naive group of people that hadn't had that previous training experience, we can say, here is the problems. So they had to learn about assessment and diagnosis, but then there's 8 workbooks that people can choose from, those evidence-based workbooks, and here is your narrow band of practice, but they're including social prescribing as well as community referral, so it's not just the CBT, and that's their scope of work. So what that does, I mean, it may mean that often experienced practitioners aren't suitable for that kind of approach. But what it also means is that those other experienced practitioners can then actually practice within this overall scope of practice. They might be seeing more complicated people, they might be seeing people for longer periods of time. So it's not duplicating or competing with those other groups, it's part of the step care approach.
So I really hear you saying that it's a complementary service that's being offered
absolutely.
here. I want to turn to Nikki now as a healthcare coach. You have been working, Nikki, for several years with people with chronic health conditions. And I'm wondering if you could share some of the benefits that you've experienced as a telephonic healthcare coach.
Yes, certainly. And I guess before I worked at Remedy Healthcare, I was working in a private practice speaking with clients face to face. When I took on the job at Remedy doing telephone coaching, I was a bit perhaps sceptical what sort of rapport I might be able to build over the phone with clients. But, from day one, it was very pleasantly surprising how much people are willing to open up to you and really deliver a very similar, if not, I'd say sometimes better service over the phone. I think not being able to see the person you're talking to might help people to open up a bit more in some particularly sensitive areas and, really get some great outcomes with people.
Because the people who access this program from within the privacy and the comfort of their own home, don't they? So that creates a level of comfort and accessibility that people don't have when they need to go and see face-to-face a health professional.
Yeah, I think that's certainly right. And there's also, clients who, for example, might be working full-time and have a busy family life. We can call them on their lunch break. People who might live rurally and can't afford the several-hour round trip to get to a clinic appointment. We can really try to slot into their lives where it suits.
So flexible and accessible, yeah. Jared, I want to turn to you now. There's a somewhat simplistic understanding, I think, that Defence Force workers are particularly affected by mental health issues. With so many mental health interventions available on the market, what was it about MindStep that appealed to you and your Defence Health members?
Yeah, thanks. That's a really good question. When people think about my fund, Defence Health, well, they say, it's quite natural that you'd have a large base that would be suffering from mental ill health. We understand if you serve in the Defence Force, you're going to be subjected to some significant trauma. But in my particular fund, about 50% of our fund have never served in the Defence Force. They've not been a supporting family member either. They're just extended family members. So maybe grandparents, brothers and sisters. And actually, you heard before from Amanda some of the statistics about what the increase from mental health that private health insurers have been funding. In my particular fund, over the last 3 years, we've had a 60% increase in members accessing in-hospital treatment programs. And all of that has come from the extended family members of my fund, not from those who've served in the Defence Force or their immediate family. So this is a community issue. And what we find that we're very attracted to in this particular program, as we've been monitoring that trend and then seeing the success of treatment programs in hospitals, we've noticed that those who do really well, those members that do really well, they've been able to participate in a program, a local program, where they're supported after their hospital treatment. And we don't get that nationally. We get it in some isolated locations. And we need a program that supports people in recovery that can be delivered nationally. And that's what Mindstep ticks all the boxes, in addition to all the other evidence-based and monitoring that we've heard about already.
Okay, thank you. I'm also interested in hearing from Nikki. We've heard a little bit about the training program for coaches, but I'm interested in how coaches are supervised through this 6-week program. Could you?
Yeah, certainly. So for each coach, we have a weekly session with our clinical supervisor. They're trained mental health professionals. And in those supervision sessions, we review each of our clients. So every new client that we've got into the program, we discuss the case and talk about what steps we propose to do. They want us to, of course, develop our own learning. So we go into the supervision session with a description of what we think is appropriate. But then our supervisor will work with us to, if necessary, steer us in the right direction. And most importantly, as Malcolm touched on earlier, if we've got any clients that do present at a high risk, it sends an immediate alert to our supervisors, and we can be in touch within a few minutes and discuss what the appropriate course of action is. So as a coach, particularly without a background in mental health, certainly feel very confident and well supported that, you know, the clients are keeping safe as well.
And the innovation there is that the oversight's all done by Malcolm remotely. It's not that the oversight's face-to-face on site. It's all, you know, underpinned by technology, and that's what enables it.
Not me personally.
No, not by Malcolm, but by
Malcolm's a busy man. Jared, you also mentioned, you were talking about the post-hospital discharge process, and I'm interested to hear from you a little bit more about that, but also I guess other panellists will have thoughts on that process, because what we're really talking about with the Mindstep program is that post-discharge process. So we need to make that clear, don't we, that these people are making a major adjustment from having been in a hospital setting to adjusting back into their lives, and that means their relationships, that means their employment, that means their parenting, that means their finances, their physical health. All of that needs to be taken into account. So what's your experience of that been?
Well, again, Amanda gave some statistics. These aren't overnight admissions. You know, the average across the industry is 20 days. That's a significant period of treatment and therapy. And for many people, of course, these are repeat admissions. Those who recover well tend to be those who are well proactively supported when they come out of hospital. And you know, we've identified and looked for where we can find programs where we can reinforce that. And of course, as I said before, that's what this program offers. You need support once you've come out of an acute setting. And this telephonic support that can be delivered nationally, so you've got a uniform outcome across my membership base, which is a national membership base, is so important.
I think that has very clearly, for me, and I hope for everyone listening today, helped make sense of how we are moving beyond the rhetoric with a program like Mindstep, and how this program really is creating an innovation that we haven't seen in the mental health space in Australia before now. So thank you all for your input and reflections.